Hello, today we will discuss diabetic foot. So this is a complication that is very common in diabetic patients. So when we say diabetic foot, we usually refer to ulcers on the foot. So foot ulcer is a very serious skin problem that is destroying not only the skin but the underlying tissues all the way to the bone of the patient. And how common do you think foot ulcers are in diabetic patients? You will actually not believe this number. I had a very hard time grasping how common this problem actually is. 1 out of 3 patients with diabetes have the risk of getting foot ulcers. You may probably think now that, yeah, you can treat it with some creams, give some bandages, some antibiotics, and that was it. Yes, this is true that most skin ulcers can be treated very well, but it is important to note now that 1 out of 5 patients with foot ulcers have to be foot amputated. And I don't want to dramatize this more, but imagine a patient now who has diabetes and is having a risk of around 30% of getting a foot ulcer, and then about 20% of those that have these foot ulcers are getting foot amputated, meaning we cut their foot. I mean, this is simply terrible. So diabetes is a very severe disease. Not only do we have to deal with amputations in patients with diabetes, but we have to deal with about 2 times more death in patients with foot ulcers compared to those without any foot ulcers. So 2 times more patients will die if they get foot ulcers than patients who do not have any skin problem. So my question now to you is now, which patients with diabetes should we check for foot ulcers? I'm saying that all patients should be checked for foot ulcers. We cannot accept amputations and death due to some problems with sugar. I mean, this whole problem starts with sugar and the body's inability to handle sugar. So when the person talks about that, yeah, I have some sugar problems, I would say that no, you don't just have some sugar problems, you have serious problems with the risk of getting amputated and the risk of dying. And the reason why I'm doing so many videos now about diabetes is because I find it one of the most common diseases in the world and one of the most common causes of death in the world. So we have now cleared that out, that all diabetic patients should be checked for foot ulcers. Okay? But now the question arises, how often should this be done? We have, for example, an international working group, and according to this group of classification, we have suggested a system, and based on that we can then tell how frequently the patient should go to the doctor's office. And let us look at the classification first. We have 4 groups, so 4 groups. We call them group 0 to 3. And the reason for calling the first group 0 is because here in this group there's no neuropathy. Neuropathy is a damage of the nerve cells that happens in diabetic patients. And about 80%, meaning 4 out of 5 patients with foot ulcers, have neuropathy. So when you see patients with foot ulcers, you can expect 4 out of 5 having neuropathy, meaning having this severe nerve damage caused by the diabetes. So neuropathy is the first part of the classification, and the question now is whether we have neuropathy or not. And if we have neuropathy, we are in group 1, and if not, then we are in group 0. Okay? Group 2 means that we have patients with neuropathy with a foot deformity also. Like, for example, a hammer toe or a loss of arch of the foot or prominent metatarsal heads or Charcot joint. So when you have neuropathy in diabetic patients, we classify them into group 1, but when you add foot deformity together with neuropathy, then you have an even more severe case that is put into group 2. Okay? Not only neuropathy is in group 2, but we also have peripheral artery disease. And this can be regarded actually as more severe than neuropathy or equally severe with neuropathy with deformity. So peripheral vascular disease is more severe than neuropathy alone. So neuropathy alone is in group 1, whereas peripheral artery disease is in group 2, which is now indicating that it is more severe. But as we said, neuropathy together with foot deformity will be regarded as severe as peripheral vascular disease alone. Okay? Group 3 contains patients with previous foot ulcers or patients with foot amputations already. And this is the most severe case. So whenever we are having patients now with foot ulcers or previous foot ulcers or amputations, then we group them into the most severe group, which is group 3. So once again, we have then groups 0 indicating no neuropathy. Next one, group 1 indicating neuropathy. Group 2, neuropathy together with foot deformity or peripheral artery disease alone. And then we have group 3, which is including patients with a history of previous foot ulcers or amputations. So now back to the question of when we need to check patients, because as we said, all the patients will be checked for foot ulcers, but the question is rather now when. So group 0 patients should be checked every year. Group 1 patients every 6 months. Group 2 patients every 3 months. And group 3 patients every month. So according to the severity now, we can group patients into those that we control yearly or every 6 months or every 3 months or every month. And that means that if you have now a patient with diabetes with no signs of neuropathy, no signs with peripheral artery disease, no previous foot ulcers or no amputations, then you group these patients into group 0, which means that you will check now the patient's foot every year. If the patient has diabetes with neuropathy, then you check it every 6 months. If the patient now has neuropathy together with this foot deformity, or if you have a patient with not only diabetes but also peripheral artery disease, then you check it every 3 months. And if you have a patient now who have already had foot ulcers or already had an amputation, then you need to check these patients every month. Every month. And these regular checkups are usually done by a family doctor or a surgeon or actually somebody specializing in diabetes, for example, some internal medicine doctors. The conclusion that we can make out of this classification is that there are 4 main body systems that have to be checked in diabetic patients. The first one is nerves. So the second one is anatomy of the foot. The third one is arteries. And the fourth one is skin. So these 4 main things have to be checked in patients with diabetes. Nerves, anatomy of foot, arteries and skin. And what do you think the most common cause of foot ulcers is? I mean, just based on this classification system, it is obvious that the most common cause has to be either a nerve problem, which we then call neuropathy, or it has to be a vascular problem, which we then call peripheral artery disease, or it has to be a foot deformity. But I would say the most common triggering factor is a small skin trauma. So yes, these 3 things, the neuropathy, the peripheral artery disease, and foot deformity, all these are very important. All these are the main underlying causes of foot ulcers. But the most common triggering factor, what I mean with triggering factor, is that the most common small spark of cause that can trigger this domino effect that we will see is a small cracking of the skin. And this can initiate a full-blown foot ulcer that can destroy all the underlying tissues, including your bones. And then we call it osteomyelitis. And as we know, skin is the protective layer now of your body, and it protects us from the outside intruders, which are bacteria, we have viruses, and these are the most common ones. And these bacteria and viruses can usually cause an infection, can cause an inflammation that can destroy the structures of your foot then, leading to severe ulcers. And in normal people, without diabetes, we have a very good microcirculation. That means a very good blood flow to the foot. And this microcirculation is very important because the immune system now travels through your circulation to the point where these bacteria and viruses are. And the question now is, the immune system in normal people can handle viruses and bacteria, usually. And it can handle these bacteria that enter into the bloodstream. But if we have a microcirculation problem, which means that the immune system cannot go there to the location where this problem is, then it doesn't matter how good your immune system is. The only way for the immune system to reach that location is through the blood. So the immune system cannot jump there. It has to travel now through the blood to this location. And therefore, when we have peripheral artery disease, which is this narrowing of the blood arteries, causing then this microcirculation problem, micro meaning small arteries, then the blood flow is reduced here, and we can say that these patients are in group 2 then, as we talked about previously, peripheral artery disease. And the question is, how can we prevent this minor trauma from happening? Normal people without diabetes and without neuropathy can feel pain and can also feel pressure. But patients with diabetes who have neuropathy, meaning they have this damage to the nerve cells, cannot feel the pain and they cannot feel the pressure. And this means that they will be able to walk on very hot stones, or they will be able to walk on very sharp objects without getting any pain. And as we know, pain is conducted through nerves. So if you do not have any nerves now functioning well, then you do not feel this pain. And if you do not feel the pain, then you will do things that you would never do otherwise. For example, stepping into a hot bath. No normal person will step into a very hot bath because it is very painful. But here we have now an old diabetic patient who just wants to take a bath every day and does not feel how hot the water is, and then steps into this hot water and destroys the skin. And this is what we call small skin traumas, or in this case it would be severe skin trauma. And to give another example of how minor trauma can happen. For example, an uncontrolled diabetic patient is putting on his shoes and he does not feel how tight these shoes really are. So he walks around with these types of shoes that are creating severe pressure on his toes and causing some small skin cracks, and the skin does not like it, so it starts an inflammation, calls for help from the immune system. And this poor little toe now will not get any help because the microcirculation is bad, so the immune system cannot reach this toe. What happens? Bacteria, some viruses will then go there, thrive, do even more damage. Patient just walks regularly as nothing has happened, and because he does not feel any pain, so he just walks on. The small toe tries to signal to the brain that this is painful, but the brain will not get the signals from the toe because the nerves that should send the signals are damaged, and therefore they cannot transport this information to the brain. So the patient continues. He continues to walk with tight shoes, with an inflammatory toe, as nothing has happened. Now let us look at third example. So for example, we have nail care. Normal people feel when the nails are too long or they are too sharp, and that would cause them pain, especially in these tight shoes. And once again, diabetic patients who have very bad nail care, who do not check their feet regularly, will eventually develop very sharp nails that will cut now the skin of the toes, and thereby they start this inflammation again. Okay? Sweat. Sweat is the fourth example of a problem which the patient does not feel, because the patient is not sensing that the foot is very moist. The receptors are not working there. Okay? Fifth example is when foot ulcers happen by patients who are smoking. Smoking will now make the arteries very narrow, and this is what we talked about already, namely peripheral artery disease. So smoking is causing peripheral artery disease. And as we know, when blood is not reaching the foot, then the immune system cannot react there, cannot reach there, and thereby foot ulcers will happen. Okay? So it is very important now that we suggest patients with diabetes the followings. Please avoid smoking. Avoid going barefoot. Always test the water temperature before stepping into the bath with your hand, because your hands are still working. Trim your toenails to the shape of the toe. Choose some shoes that fit perfectly. Change the socks every day and check your feet every day. Okay? A last thing that can be added is that doctors should always be very careful what medications they give patients to not worsen the peripheral artery disease or to not worsen neuropathy. And one diabetic medication has gotten a warning now, which is called canagliflozin. And this belongs to the group of SGLT2 inhibitors. It has been seen that canagliflozin can increase the risk of foot ulcers and amputations in patients who already have peripheral vascular disease or already have neuropathy or foot deformity. But please remember that canagliflozin can be given in patients with only diabetes without these vascular or nerve problems. Okay, it's just increasing the risk when you have these diseases also. So if we go back now to the classification that we dealt with in the beginning, meaning neuropathy or neuropathy with deformity, then you may ask why deformity is an issue. So a normal person is usually born with a foot that is anatomically and functionally almost perfect. And this means that the pressure on your foot bones are normal. So whenever you have a deformity, for example, the foot arch is flattened, or some other bony deformity, the weight of the patient is causing them pressure on these certain bones that then get inflamed. So it's anatomically and functionally not perfect. Okay, so until now we have looked at the main causes of foot ulcers and we have classified foot ulcers into 4 main groups, as we said, and then we have to now look at what we doctors can check for. So what do we do as doctors? And I will start checking the most serious things. For example, this is group 3 patients, namely those who had a previous history of ulcers or those who already were amputated. So we start with a simple question. Have you ever had a foot ulcer before? If the answer is yes, then we know that this is group 3, which is the most severe one. We know that 1 out of 5 patients who already had a foot ulcer will eventually need an amputation of the foot. So it's very important that we start with this. We also know that around 4 out of 5 of these patients have neuropathy. So when it comes to those patients already having amputation, we know that the risk of dying is also very high. So we need to check these patients really every month. And if the patient has a foot ulcer at the moment now, then we need to check the skin of the patient, especially the color, the thickness, the dryness, the cracking of the skin, and so on. And we need to fix also the nail care. We need to fix that the patient has proper shoes. We have to treat any fungal infections that can happen between the toes. And we have to check if there's any infection. So signs of infection are, for example, redness, warmth, tenderness, swelling, and even pus coming out of the ulcer. Okay, pus, a lot of bacteria. And whenever there is pus, there's usually very, very bad odor, which means that it is important to drain this pus coming from the wound, and it is very important to check the underlying structures like the tendons or the joints or even the bones, because when bone is seen at the floor of this deep ulcer with a size that is more than 2 centimeters in diameter, and at the same time we see in the laboratory an elevated erythrocyte sedimentation rate or an elevated CRP values, then these things can indicate that we have a severe osteomyelitis. And osteomyelitis is a very severe complication because now we are talking about an infection of the bones, which is very hard to treat, and it can quickly spread to the other parts of the bone. Okay? And whenever now we suspect this osteomyelitis, we have to take lab values, as we said, where we will see now elevated erythrocyte sedimentation rate or elevated CRP values. And we will also now make an X-ray, so X-ray first, and if there's any indication of bone damage, then an MRI is important to do because it is more sensitive than X-ray in diagnosing patients with osteomyelitis. So the first thing we said was to check the skin and ask the patient of any previous ulcers or amputations, because these are the most severe cases. Okay, and then we go on and then we check if the patient has any peripheral artery disease, which is in group 2. And here it is important to first look at the foot and leg for any signs of peripheral artery disease. And the signs usually are claudication by walking for a certain distance, for example. The patient complains about pain after walking only after a couple of meters. And we have to also check if the legs are very cool, if the skin is thin, if there's absence of skin hair, if the color of the skin is rather bluish, and if it is not possible to palpate the foot pulses, or even worse, if you cannot palpate, the popliteal or femoral pulses. And these are the most common signs of peripheral artery disease. But we also need to make a test which is called ankle brachial test. In this test, we will now measure the blood pressure. We'll measure it in your arms, on your arms, and then we'll compare that to the blood pressure in your ankles. So we divide the value of the blood pressure in your ankles divided by your arms, and therefore it is called ankle brachial index and not brachial ankle index. And as we know, the blood pressure in your legs due to gravity has to be more than in your arms. And this would now mean that you divide a higher value, which is the ankle value, divided by a lower value, which is the arm value, which would then give you a value that is more than 1 due to gravity. And if this is not the case, if we have a value that is less than 1, especially less than 0.9, then we can be very certain that the patient has peripheral artery disease, because the arteries are narrowed in the legs. And if the patient has signs that we mentioned before, the signs were claudication by walking, which means pain by walking a certain distance, cool extremities, thin skin, absence of skin hair, bluish skin color, absence of foot pulses or popliteal or femoral pulses. These signs, together with an ankle brachial index of less than 0.9, indicates peripheral artery disease, which then has to be checked by a vascular surgeon. Because a reconstructive vascular surgery will help more than 80% of patients with healing their ulcers, and the results are far better than if you do not do this operation. But the surgeon has to make the indication. He has to tell the patient if it's needed or not. So the tests that we have performed until now, we're first looking at the skin. Then we asked for any previous ulcers, we checked any amputations, and then we had a testing if the patient has peripheral artery disease with an ankle brachial index. But as we know, in group 2 there is also not only peripheral artery disease, but we also have neuropathy together with this deformity, foot deformity. This means that we will look at the foot structure, the anatomy of the foot, if the arch is normal, if there's any Charcot joint, if the toes are normal in shape, and if there are any calluses, so any hardening of the skin of the foot due to some high pressure. Then we will go on and look for neuropathy. And we have some tests now that we can perform to diagnose neuropathy. We will now test the ability of nerves to sense pressure, sense vibration, pain, hot and cold temperature, and we will also look at the nerve reflexes. And then finally we will ask some questions based on the neuropathy symptom score test. Okay, this is a scoring system. So if we start with pressure now, how can we test pressure? We will use a 10-gram monofilament test. This 10-gram monofilament test will be tested on 6 sites on each foot, at least 6 sites, namely on the palmar region of the big toe and the fifth toe, and also on the metatarsophalangeal joints of the digits 1, 3, and 5. And then we will also test it on the heel. Okay, and as you hear from the name here, we're applying a 10 gram of pressure, which the patients with neuropathy cannot feel. Normal persons could feel it automatically, but patients with neuropathy would not feel even 10 gram of pressure. And we have this small filament that is not felt. And these 6 regions of each foot are important to note, while then you know where the patient is not feeling the pain when he's walking, and then that could then lead to inflammation in this part that we talked about previously. So that was pressure. Now let us look at the vibration. So we will use now a tuning fork. A tuning fork is vibrating with 128 Hertz. And we will now put this tuning fork on the bony part of the dorsal part of the first toe, just before the nail bed on the toes. And we will ask the patient to sense the start of the vibration and then the end of the vibration. And we will repeat this test at least 2 times on each toe. Okay, so that was pressure and vibration. Now let's look at pain. Let us look at pain. So pain can be checked by a pinprick test, where we apply a very sharp object on different parts of the legs and also on the foot, and then the patient simply has to tell if it is painful or not. That was pressure, vibration, and pain. Then we will check cold and warm temperature. cold and warm temperature sensation. So here we have an object which has on one end a cold surface and on the other end it is a hot surface. And we will apply this hot and cold on the patient's skin very randomly, and the patient has to tell if it is hot or cold. The last test that we will do is to check the reflexes of the nerves. That means that when you punch the nerves, then a signal will go to your spinal cord and automatically release some signals to the legs, so to the muscles, to contract. And on the legs we have two reflexes that we usually check. One is the patellar reflex, or also called the knee jerk reflex, and the other one is ankle reflex. And in neuropathy, these reflexes will simply not work, or they will be less at least. So regardless if you punch the patellar region or the ankle region, the leg will simply not move or move very, very less. So less activity. So in conclusion now, we can say that things that you have to test on the lower legs are once again pressure, vibration, pain, hot and cold temperature, and ankle reflexes. The tests are called 10-gram monofilament test, 128 Hz tuning fork vibration test, pinprick test, hot and cold temperature test, and ankle reflex test. And if we see that any of these tests are showing some signs of neuropathy, then we have to ask some questions, and these questions are based on the neuropathy symptom score. So we will ask 5 questions, and these are: what is the sensation felt? What is the location of the symptoms? Have the symptoms ever awakened you at night? What is the timing of symptoms? How are symptoms relieved? And once again, the questions are sensation, we have location, awakening at night, or the timing, and the symptoms relieved by something. And depending now on what the patient answers, we will give some points. Let's start with sensation. If the patient answers that he feels burning, numbness, or tingling, then we give 2 points. Whereas if he answers that he feels fatigue or cramping or aching, then we only give 1 point. Then we ask about location. If he answers that his feet are affected in the then we give 2 points. And if the feet are affected, then we give 2 points. If the calves are affected, then only 1 point. If the symptoms awake him at night, then we give 1 point, otherwise no point. If the timing of the symptoms are worse at night, then we give 2 points. Otherwise, if it is the same during the day and night, then only 1 point. If the symptoms are relieved by walking around, we give 2 points. And if they are relieved by standing, then only 1 point. And based on these points now, we can now classify neuropathy into normal, mild, moderate, and severe. 0 to 2 points is normal, 3 to 4 mild, 5 to 6 moderate, and more than 7 then severe. So these are the main things now that we have to check. All the tests that we mentioned now for neuropathy and these questions to classify patients into normal, mild, moderate, or severe have to be done. Okay. So one more thing to do before saying that this is certainly neuropathy due to diabetes is to check the vitamin B12 levels in the patient's blood. So B12 deficiency is a very common cause of neuropathy-like symptoms. And if the case is that the patient has low levels of vitamin B12, then we need to supplement it and look for any improvement in the patient's signs. And if we do not see any signs of improvement, or actually we see a worsening or the patient stays the same, then we are pretty sure that the neuropathy is caused by diabetes. Okay? So now, to summarize, all the tests that we have to perform are based on our classification of foot ulcers. We divide the patient into 4 main groups. We said group 0 are those with no neuropathy, group 1 with neuropathy, group 2 with neuropathy and deformity, or peripheral vascular disease or peripheral artery disease alone. And then group 3, those with a history of foot ulcers or history of amputations. And we always start with the tests that look for the more severe things, namely the ulcers and amputations. And that means we have to look at the skin first. We look at the color of the ulcers, any pus, any inflammation signs, the nail care of the patient, the shoes of the patient, signs of any fungal infection. Then look for deformities of the foot, for example, Charcot joints or hammer toes. And then after that, we will look at the peripheral artery disease signs, which were claudication by walking with cool extremities, thin skin, absence of skin hair, bluish skin color, absent of foot pulses, absent popliteal or femoral pulses, and then finally we perform an ankle brachial test, which has to be below 0.9 to suggest that this is peripheral artery disease. Then we make tests for diagnosing neuropathy, and we will look for pressure, vibration, pain, hot and cold temperature, and ankle reflexes. And we will do that with the following tests. We have 10 gram monofilament test, 128 Hertz tuning fork vibration test, pinprick sensation, hot and cold temperature test, and ankle reflex test. Finally, we will ask these 5 main questions that we had, which were then based on this neuropathy symptom score. And here we ask what the patient, what sensation he feels, what the location of symptoms are, if it ever awakens the patient at night, what the timing of the symptoms are, and finally, if the symptoms are relieved by anything. Based on this, we give some points. We classify patients into normal, mild, moderate, or severe. And we will do these tests for all patients, as we said, with diabetes, all patients. We'll do it every year for group 0 patients, every 6 months for group 1 patients, every 3 months for group 2, and every month for group 3 patients. So I hope you now know a little bit more about diabetes and its complications affecting the foot. So diabetic foot. Please take care of yourself now and watch out for diabetes, and please watch out especially for foot ulcers. Thanks a lot for listening. Take care. Bye bye.